Dr. Glassuk, welcome back. We're going to move on to Dr. Glassuk's second talk now on FSGS. Thank you very much.
Thanks very much for having me back. And here are my disclosures on this talk on primary FSGS. I must say a little similarity with the previous talk on primary aldosteronism. Things are changing and changing rapidly. Anyway, I have lots of disclosures. I'm sort of involved in this field in a very deep way, but I'm not beholden to any one of these. So in this talk, I'm going to try to get 3 points across. One, the lesion of FSGS and its categorization according to pathogenesis, the prognosis of apparently, and I put apparently in quotation marks because it's often difficult to establish true primary FSGS, and the therapy of primary FSGS, not genetic, not unknown, not secondary, but primary FSGS. So let's start with the lesion of FSGS, focal and segmental glomerulosclerosis. Well, you've seen this from all textbooks. This is a single glomerulus affected. There may only be 1 out of 10 or 1 out of 30, 1 out of 40, but it shows this pathologic lesion of focal scarring, rather segmental scarring in the proper term, often with hyalinosis shown in the pink material and the arrow pointing towards the sclerotic lesion. The remainder of the glomerular tuft looks pretty normal. Well, like the first talk, I like to start with axioms that you should remember. FSGS is a light microscopic lesion. It is a pattern of injury. It is not a specific disease entity, and it should not be viewed as such. It is one of the numerous patterns of injury observed in diffuse podocytopathies. The extreme heterogeneity of pathogenesis underlying this lesion must be taken into account in evaluating prognosis and deciding on appropriate therapy. Therefore, the treatment of this lesion must be based on its specific category, largely pathogenesis related, and is highly individualized. At the present time, according to both guidelines and published data, we have 4 modern classifications of the FSGS lesion. Primary, probably related to a permeability factor, probably autoimmune in nature. Genetic FSGS, secondary FSGS to a wide variety of disorders such as obesity and drugs and some infections, and then, of course, a waste spot category that doesn't fit any of the first 3. Primary permeability factor or autoimmune FSGS is not a pathological diagnosis. It is a clinical and pathological diagnosis, and it involves clinical features such as the sudden onset of full-blown nephrotic syndrome with proteinuria commonly above 8 grams per day and hypoalbuminemia. No family history of CKD, no syndromic features, no drugs or viruses known to provoke the lesion of FSGS, and no proven genetic cause. The lesion itself can be quite varied. In fact, there are many different light microscopic appearances of primary FSGS, but typically, at least in untreated patients and in a pretty relatively uninvolved glomerulus by light microscopy, you see diffuse, typically over 80% foot process effacement by electron microscopy. Unfortunately, at the present time, there's no proven serum or urinary biomarker specific for this diagnosis. However, anti-nephrin antibodies, once they become commercially available, may be an exception. a positive anti-nephrin antibody result and a lesion of FSGS may be sufficient to diagnose primary FSGS, at least in the autoimmune form. We know from a number of studies that these lesions and this patient has a very high risk for recurrence of the same disease in renal allografts. That is, it is a systemic disease process, not one confined to the kidney. Now, it comes, as I said, in a lot of different varieties. I show three here, the tip variant, the not otherwise specified variant, and the collapsing variant. And this accounts for about 90% of all the FSGS lesions. Unfortunately, although this is interesting pathologically, it doesn't have much clinical utility. And many pathologists no longer report the histologic variants because they don't have a lot of clinical utility. The entity of biopsy-proven FSGS does not exist. You cannot be certain that this is the primary autoimmune form of FSGS looking at the light microscopic electron microscopy alone. You must integrate the clinical features and, in the future, serologic features such as anti-nephrin antibodies. The pathogenesis is believed to be due to a circulating permeability factor, and anti-nephrin antibody is the leading candidate. We don't know precisely what percentage of patients will have an antibody detectable. This depends on the assay used, the sensitivity, when the measurement is made, before or after treatment, and so forth. Although I've emphasized anti-nephrin antibodies, there are other potential permeability factors, including antibodies to other components of the slit pore membrane in the kidney. Anti-nephrin antibody is highly related to the risk of recurrence of this disease. A very nice study done by Hattori, first presented in Milan in 2023, subsequently published and now confirmed that a patient with high levels of detectable anti-nephrin antibody has virtually 100% risk of recurrence of the disease in the transplanted kidney, showing unequivocally that these autoantibodies are pathogenic. Unfortunately for the clinician, there are no currently available FDA-approved assays for these antibodies, and it's mostly a research laboratory procedure, which has no clinical utility in that it can't appear as a chart or an official part of the hospital record or the clinical record. I think this is going to be corrected in the next couple of years, and that I would be very surprised if we don't have a FDA-approved assay that will be made quite readily available. But there's no doubt that anti-nephrin antibodies are involved in FSGS. This on the left is a microscopic view of the immunofluorescent pattern seen in anti-nephrin positive FSGS, a dusting of the podocyte, which on confocal microscopy in the right-hand panel shows co-localization of IgG and nephrin in the same location at the podocyte level. Now, the electron microscopy is useful in FSGS because in primary FSGS, in less involved glomeruli, before the treatment process begins, should show diffuse foot process effacement as shown in panel A's and B by electron microscopy, whereas many forms of non-primary FSGS show a more segmental involvement of the glomeruli and many normal foot processes, despite the fact that the lesion by light microscopy appears the same. Now, genetic testing of patients with FSGS lesions is very useful because it can direct the choices of treatment and particularly leading to the avoidance of ineffective regimens. And in adults with a lesion of FSGS, about 30% will have a monogenic mutation detected, either COL4 or a podocyte gene, rarely both. Now, these are in patients who often also show steroid resistance. What is the prognosis of the primary form? Here we're not talking about genetic forms or secondary forms of FSGS. Older retrospective studies, not incorporating genetic analysis, showed that the FSGS lesion is a progressive one in terms of loss of renal function, particularly if the patient does not exhibit a response, that is, a partial or complete response in proteinuria. Obviously, in the genetic forms of FSGS, the prognosis is poor because so few ever develop any kind of a remission upon therapy. So even a partial remission of proteinuria has been known to have some protective effects on renal survival for many, many decades. In this case, more than 20 years. The level of proteinuria relates very directly to the rate of progression of GFR. Here, a nice study from Dan Catran shown in red, patients with the lesion of FSGS, not necessarily primary. This is confounded by inclusion of genetic. The increase in decline in GFR begins relatively early with proteinuria above about 1.5 grams to 2 grams per day, and then it progressively increases with higher levels of proteinuria. So I want to spend most of the time on the current approach to treatment of primary FSGS, non-genetic, non-secondary, who meet the clinical pathologic criteria for primary FSGS. Well, fortunately, we have some guidelines on this. Unfortunately, they're 5 years old, but KDIGO recommended that these patients be treated with immunosuppressive agents, steroids, or a CNI, even without genetic testing. Unless there is a family history present or a syndromic presentation, this may even be irrespective of the subvariant of the lesion by light microscopy. Genetic testing, on the other hand, should be seriously considered. I happen to think it's mandatory if the patient is resistant to either steroids or calcineurin inhibitors, and that in 2021, the initial treatment of choice was high-dose oral glucocorticoids for patients with presumed primary FSGS. That is now changing, and I think future guidelines will take a quite different approach rather than using steroids. But that is the current KDIGO recommendations 5 years previously. CNIs, alone or with low-dose steroids, can also be used for initial treatment of patients with primary FSGS, particularly if there are relative or absolute contraindications for high-dose glucocorticoids. So initial treatment, steroids or CNIs, depending upon the characteristics of the patient. The steroid regimens have been again defined by KDIGO. They're fairly high-dose steroids, continued for at least 4 weeks or until complete remission is obtained, or for a total of 16 weeks. I can assure you that 16 weeks of steroids in high dose will produce side effects in nearly every patient with FSGS, and often these side effects result in the early termination of steroid therapy. CNIs, either cyclosporin or tacrolimus, can be used. Trough levels are usually measured largely to avoid toxicity, and the treatment duration is long, at least a year, unless patients after 4 to 6 months have no effect at all. In that case, treatment can be, in fact, discontinued. Steroid therapy can be quite effective. Overall, about 60% of patients respond with either a partial or a complete remission. And in the responders, those who develop a complete or partial remission, the 10-year renal survival is quite good. Of course, those who don't respond have a very poor prognosis, and there is no real difference in the long-term response between patients with TIP, not otherwise specified, or collapsing lesions. It takes time with steroid treatment to achieve a complete remission. In this study of 100% of patients who developed a complete remission, it took 12 weeks to achieve a complete remission in about 50% of the patients. So prolonged treatment is required, and thus steroids are associated with a high complication rate. Now, interestingly, the initial response to steroids much sooner than 16 weeks can predict the later response to treatment, either as continued steroids or with the addition of an alternative drug like CNIs. A decrease of greater than 20% in proteinuria compared to baseline within the first 8 weeks is strongly associated with the subsequent response to steroids and or the addition of some alternative agent like a CNI. 96% of patients having such a greater than 20% decrease showed a long-term beneficial response with a high percentage of complete response. So you can identify the unresponsive patients far sooner than 16 weeks, probably on the order of 8 weeks, by continuous monitoring of the magnitude of proteinuria. So the change of proteinuria within the first 8 weeks may be a useful surrogate biomarker of steroid-resistant disease. Now, cyclosporin and other calcineurins have been shown in randomized controlled trials to have a beneficial effect on proteinuria, but that effect is not lasting. Once you stop the cyclosporin or tacrolimus therapy, a relapse is likely. Here are patients treated for 6 months, the first 2 bars, with this drug showing a high likelihood of a complete or partial remission. But once the steroids are stopped, or once the calcineurins are stopped, the patients, not all of them, but many of them, will develop a relapse. So these CNI agents are not 100% disease modifying. Now, the choice between steroids and CNIs for initial treatment are largely based on individual patients' characteristics, but the long-term outcome at 3 years is not much difference between those who are treated initially with steroids versus initially treated with CNIs. So CNIs can, in fact, substitute completely for steroid monotherapy in the treatment of primary FSGS, and this has led some physicians to abolish use of steroids entirely, that is, converting to an initial regimen of calcineurins inhibitors. Now, the new kid in the block is anti-CD20 therapy, mainly with rituximab. Later, I'll show you some data on obinutuzumab, in that these drugs do have a beneficial effect on the outcome of primary FSGS, particularly in the steroid-dependent and relapsing forms of primary FSGS, but it can also be quite effective therapy for the initial management of primary FSGS, that is, avoiding both steroids and calcineurin inhibitors. We don't have any good randomized control trials yet for rituximab monotherapy as initial treatment of FSGS lesions in adults, but it seems to be likely that it will be effective, and data is now emerging that it may be more effective in patients with primary FSGS who have positive anti-nephrin antibodies. Here is rituximab, a nice study of rituximab in primary FSGS in adults in the steroid-resistant category and in the steroid-unresponsive or dependent category. Only one patient in the steroid-resistant category responded to rituximab, and all of those remissions were partial, whereas the majority, not 100% of patients in the steroid responsive and dependent category responded to rituximab. Now, what about rituximab in those patients who get CNIs and are resistant? That is, they don't have any beneficial effect after 6 months treatment. Chan did a nice retrospective observational study in children, not adults, with either an FSGS lesion or a minimal change lesion. And in fact, complete and partial remissions were seen in 35% of patients in CNI-resistant disease, about half complete remissions and about half partial remissions. Now, if rituximab is effective, maybe obinutuzumab will be more effective because, as you know, although it's an anti-CD20 monoclonal antibody, it does have properties of deeper immunologic efficacy. And in that case, it might be a better agent. Well, Zand and the colleagues from the Mayo Clinic presented a paper at the ASN Renal Week in 2024, 20 cases, all of whom had nephrotic syndrome and a GFR above 20, and 55%, that's better than rituximab, reduced their proteinuria 50% or more from baseline, and 8 out of 20 had a complete or partial remission at 12 months. That's much better than has been reported in retrospective studies. Here's the actual data from that study. These patients all had resistant, that is, drug-resistant forms of FSGS. And shown in blue is what happens to proteinuria. 10 grams at baseline, 7 grams at 6 months, 3.8 grams at 12 months. And this is statistically significant. Now, this is not a randomized control trial. It's an observational study. It's hypothesis generating, but it has led to the understanding that there is a distinct possibility that obinutuzumab may be the preferred anti-CD20 agent. Management guidelines, which are beginning to be published, are gravitating away from initial therapy with high-dose steroids or CNIs in primary FSGS and towards greater use of anti-CD20. And I think sometime this month you may see the up-to-date suggestions for management of primary FSGS, and they would be worthwhile looking at to see what guidelines are emerging in management. Now, when you have a resistant patient to everything, some people then resort to plasma exchange or lipid apheresis. We don't have any good randomized control trials, but large accumulated data from observational studies suggest that you can achieve a complete or partial remission in such patients with either plasma exchange or lipid apheresis or immunoabsorption, well, maybe even immunoabsorption in such patients, and that this may contribute to better outcomes. But of course, this is limited to observational studies. Finally, Acthar gel has been shown to have short term effectiveness in multi-drug resistant, but as far as I know, there has never been a confirmatory RCT that's yet been performed. There is no evidence that Acthar gel improves long-term outcome. Maybe such data will eventually become available. What about SGLT2I, which are used in many patients with CKD? Only one such study has been published. This is from the DAPA CKD trial. And SGLT2 do reduce proteinuria acutely, and they seem to stabilize the course of EGFR over the long term. But as yet, that's not statistically significant. And you'll note that at 28 months, there's no difference in the EGFR in patients with steroid-resistant FSGS by the addition of an SGLT2 inhibitor. I'd like to finish with a few comments about sparsentan, which, as you know, has recently been approved for the use in patients with FSGS lesions, not necessarily defined as primary. This stems from the DUPLEX trial, which was published in 2023, 371 patients, not necessarily with primary FSGS. It was a heterogeneous group, and all of whom had proteinuria greater than 1.5 grams per day, but many did not have nephrotic syndrome. So this is not a randomized trial of treatment of primary FSGS with nephrotic syndrome using sparsentan. They used a surrogate pre-specified endpoint at 36 weeks, achievement of a UPCR less than 1.5 gram per gram, and a 40% reduction from baseline. Pretty characteristic baseline, but the main feature in this DUPLEX trial is that serum albumin was normal. Thus, these patients did not have or had either primary FSGS in partial remission, but they did not at outset have primary FSGS with nephrotic syndrome, and genetic FSGS was present in almost, 18.8% of the patients. Well, it did show that sparsentan lowers proteinuria. In the center bar, blue is sparsentan, and gray is the control arm, irbesartan. And complete remissions at any time appeared to be much higher with sparsentan, 18.5% versus 7.5% in the irbesartan group. So sparsentan does produce sustained reduction in proteinuria and probably an increase in complete remission rate in a heterogeneous population of patients with an FSGS lesion, but without or nephrotic syndrome. The EGFR slopes weren't significant in this study, and probably because they were a heterogeneous population of patients. It seemed that the effect was significant, or at least tending towards significance in the genetic form of FSGS, which, as you know, we don't have any good treatment for at all at the present time. There has been long-term follow-up of patients treated with sparsentan and FSGS lesion, and very clearly, these patients do have sustained EGFR or UPCR responses with a significant decline in proteinuria. However, despite this change in proteinuria, which is sustained, these patients can continue to progress towards end-stage renal failure, with an increasing percentage of patients having a confirmed 40%. So there is a bit of a disconnect between the antiproteinuric effect of sparsentan and its effect on GFR. But patients who develop a complete remission of proteinuria do tend to be protected from progressive disease. Now, the corresponding radar and parasol studies have suggested that the development of a major remission, in this case, values of protein less than 0.7 grams per day, is strongly associated with protection from a composite kidney failure event. The slope of eGFR is much less valuable in assessing these effects due to an intrinsic variability probably contributed to by the very heterogeneous nature of the patients enrolled in the DUPLEX trial. As you know, sparsentan was approved on April 13th for the treatment of patients with an FSGS lesion. It did not say treatment of patients with primary FSGS, and the approval was only for non-nephrotic patients. And it was not for reduction in the rate of progression of GFR. It was for a reduction in proteinuria only. It did not specify, designate a threshold or maximum level of proteinuria for eligibility, and the approval is not specific for the categories of FSGS lesion. For the FDA definition of nephrotic syndrome, it was proteinuria, hypoalbuminemia, and edema. So a patient with primary FSGS who is in a partial remission of proteinuria and nephrotic syndrome without edema and without hypoalbuminemia may be a candidate for sparsentan therapy. Now, there's a big, long list of drugs which are in the process of being evaluated for FSGS. I suppose that some of these may eventually reach approval, but at the moment, I don't know which one of these is going to be the first agent to receive approval for primary FSGS with nephrotic syndrome, other than ACTH, which has been approved since 1970 for nephrotic syndrome and absence of uremia. So the take-home messages for today are: the lesion is very complex, very varied, with many different pathogenetic mechanisms. The pattern of injury lesion is insufficient to guide treatment decisions, and it must be properly classified into the categories of FSGS shown in the bottom of this slide. Underlying genetic mutations are common, and the primary form, non-genetic, clinical pathologic divide of FSGS is susceptible to treatment, steroids, CNI, or anti-CD20. Anti-CD20 may become the preferred management strategy, particularly obinutuzumab. We still don't know how to manage multi-drug resistant forms of the FSGS lesion, but obinutuzumab, rituximab, and Plex may be an effective approach, and sparsentan is now a commonly used drugs in non-nephrotic patients with the lesion of FSGS in various categories. Thanks very much. I'll be happy to take some questions.
All right. Thank you very much, Dr. Glassock. So